Hello, and thank you for joining us today. My name is Christina Silcox. I'm the Research Director for Digital Health here at the Duke-Margolis Institute for Health Policy. Welcome to our workshop, From Principles to Practice, Exploring AI Governance in Health Systems, which is being convened by the Duke-Margolis Institute and our partners at Duke Health. A comprehensive AI governance system has many advantages, including ensuring patient safety, maintaining ethical standards, fostering trust, and managing privacy and regulatory compliance, among other issues. But right now, we don't really have the clear best practices to use to establish these governance processes. So during this webinar, we'll briefly discuss our recently released white paper, AI Governance in Health Systems, Aligning Innovation, Accountability, and Trust, and then hear from an array of experts to better understand the benefits and challenges in implementing AI governance within health systems. We will also discuss opportunities to democratize AI governance to ensure that everyone is able to benefit from these novel tools. But before we begin, I'd like to go over a couple of quick housekeeping notes for today's meeting. Next slide. First, I want to acknowledge our commitment to academic excellence and to avoid taking partisan positions in our work. You can find more information about our policies on our website. Next slide. All of the meeting materials will be available on the Duke-Margolis event website after the meeting. To our attendees, please type any questions into the Zoom Q&A during the sessions, and we'll try and get to your question. And a recording of the meeting will be available on the Duke-Margolis event website after the conclusion of the event. Next slide. So before we jump into the meeting, I want to quickly go over today's agenda. We're going to begin today's workshop with a high-level presentation from my colleague at Duke-Margolis discussing findings from our latest white paper. Next, we're going to bring together a group of experts in a health fireside chat to discuss shared benefits and lessons learned from building out their AI governance bodies at their organizations. And finally, we'll conclude this webinar with a panel discussion to talk about how to democratize AI governance so that more health systems and patients can safely benefit from these technologies. Our meeting is going to adjourn at 1:30 p.m. Eastern Time. And now I'd like to invite my colleague, Valerie J. Parker, Policy Research Associate at Duke-Margolis Institute, to kick us off with an overview presentation of our white paper. Val, whenever you're ready.
Great, thanks so much, Christina. So hello, everyone. My name is Valerie Parker. I'm a Policy Research Associate here at the Institute, and I'm really excited to speak with you all today about our recently released white paper entitled AI Governance in Health Systems, Aligning Innovations, Accountability, and Trust. Next slide. So this white paper is available on our website, and I believe there's a link that's just been dropped in the webinar chat for you all. And so it covers our research project that we've been working on for over the past year. We convened a working group of experts to discuss AI governance in health systems and better understand what are the benefits, what are the lessons learned, what are the common components of this type of structure. In addition to our working group, we also conduct interviews with different health system stakeholders. And we also convened an expert workshop to bring in some additional perspectives, including developer perspectives and other researchers, to just get a better sense of this space. And so this white paper really encompasses those findings. I'm going to walk you through some of those findings today. And then, of course, if you want any more detail, please visit our website. Next slide. So, of course, just want to say a huge thank you to our working group members for all their wonderful insights, without which this project wouldn't have been possible. Next slide. So what exactly is AI governance? We defined AI governance as a practice of reviewing, assessing, and evaluating individual AI tools to ensure they can be used safely, fairly, responsibly, and effectively within a health system and in compliance with applicable laws. Now, I did want to provide a distinction between AI governance and AI strategy. So while the governance is more about that review process, strategy is that more high level prioritization for the assessment, for the implementation, to make sure it's aligned with the health system's overall mission. Next slide. So I wanted to go over some key components that we've identified of AI governance. Identification and registration of AI tools, tool review and assessment, monitoring surveillance, and organizational alignment and engagement. Now, I'm really going to focus on the top two here and just do kind of like a brief overview of the bottom two. Next slide. So let's start with the identification and registration process. First of all, for AI governance, what we saw is that there needs to be a system to identify those AI tools so they can undergo a review. So generally what takes place is some workforce education, letting staff know that there is a new AI governance process through training, through advertising. So they know who to go to with that information of, I want to implement this tool in my department, etc. What we've also seen is that health systems have implemented some fail-safe mechanisms with additional training, whether it be through their IT departments or procurement, so that if IT sees an AI tool in use, they can flag the governance group, or similarly procurement, should a department begin the procurement process for a certain AI tool, they're flagging the AI governance group right away. So we've seen a mix of approaches here. Once a tool has been identified, we've seen organizations build out an inventory of tools so they can keep track of these tools in the future, and then collect relevant information afterwards. So you have the tool, but what information is needed in order to conduct that governance review and assessment? What we've also seen some governance groups do is actually do more of a retrospective look back of the tools that were implemented before the governance body was formed. So that could be, for instance, the governance body was formed in 2022, like, oh, we had some AI tools that were implemented in 2018, going back and making sure that there's a review and an assessment done there. So it can vary a little. Next slide. So the next key component that we've identified is, of course, probably no surprise, the tool review and assessment process. So what we're seeing here in this lovely graphic is just how many different topic areas you could review. I will say this is not comprehensive, and it certainly varies from organization to organization, but wanted to highlight a few for you, including data use, privacy, bias, safety, and clinical integration. What we typically see is that there is like a different review member who will go through each component and bring it back to the governance group. Then after this review, there's generally an assessment done, and that can be based off of internal data validation, flagging relevant concerns to the appropriate decision maker, as well as suggesting any mitigation strategies. Next slide. And so here are these other components that we wanted to touch on. So monitoring and surveillance. What we've seen is that once it's gone through the review process, you can do just a pilot phase implementation because the process can be iterative. So the tool can be implemented in a pilot in silent in the background to gather more information. And then that information can be taken back and re-reviewed, assessed, and a new recommendation formed for whether it's going to be a permanent implementation. What we've also seen is just that post-implementation monitoring as well to ensure that the tool is performing as expected. What we also saw and wanted to emphasize really is it's important to designate accountability to specific staff members to review the tool to make sure it's functioning as expected. So that's one way, one mechanism that we've seen. The other way we've seen is kind of a more proactive approach with the governance group to conduct like annual audits on these tools that they've built out in their inventory. And the last point here is organizational alignment and engagement. So having that open line of communication with the health system decision makers, the government's isn't operating in just a silo, but there is that line of communication, which kind of gives the governance a bit more backing, a bit more authority. So they're not just releasing these reviews and no one is actually reviewing and assessing. So that line of communication is important. And so that brings me to my next slide, which is tailoring an AI governance approach to your health system. So what I went through just now were more of those common components, but now I'd like to focus on where we're starting to see variations and how you can kind of configure it to make it your own. So these loosely fall into two buckets, which were process-focused variations and people-focused variations. So I'm going to start with the process-focused variations. Next slide. So one consideration is, where is this governance going to live, essentially? Do you build it into your existing health system governance structure, or do you create a separate process? And this can really vary with the organizations. If an organization has they feel really confident in their current governance approach, they might just add an AI expert and then continue on their way. But if they'd like to really build out a separate structure, which we've also seen done, then they would do so as well. Another aspect to this is what tools are in scope. So I've been saying AI governance, artificial intelligence, but how is that defined at your organization? Because we've heard a few different definitions. We've heard AI is just anything that's just an algorithm, anything algorithmic, it falls into that bucket. We've heard from organizations who said, we're going to cover most AI tools, but we're going to treat Gen AI a bit differently. It's going to go through a different process, different governance process than our standard AI governance, because there's different considerations. And we've heard kind of every way in between. So that's definitely one key consideration that you want to ensure you're thinking through is, how is AI defined and what will governance be reviewing? We've also heard that whether or not a tool, if the tool has been reviewed and approved by FDA, if that changes at least how it moves through the governance process. So lots of considerations there. Another aspect to this is whether or not to limit AI governance to just clinical tools, including, or you want to include operations tools, administrative tools. For instance, if there's AI used in the billing department, does that need to go through the same AI governance structure as a clinical tool? Next slide. And so then there's also some people-focused variations as well. So who is actually on this AI governance body? Who represents this sort of day-to-day review group? And what specialties, if you recall back to my slide with the graphic before, which of those specialties are most important to your organization? Which ones do you want to focus on and ensure are included to form a robust review? Similarly, when it comes to the decision-making authority, who has the final decision and who is the governance group issuing a recommendation to? We've heard from some groups that it's the C-suite, it's like the chief informatics officer who would be making that decision. But with other groups, it's the department that will be utilizing the tool, implementing the tool, whose budget will fund the tool. That business owner or that department lead has that final say. And finally, what we heard from our health systems that we talked with was how to best incorporate the patient voice. And we heard that they were grappling with this idea. Some approach this through patient councils and going to patient councils to get their perspectives. Utilizing bioethicists was another way to incorporate the patient voice. But overall, we've seen that it's still a work in progress as how to make sure the patient perspective is heard in this space. Next slide. So that brings me to my final slide, stakeholder actions. And so these are actions that some are already ongoing and that we'd like to see even more of. So we've broken it out by different stakeholders. So the first is the government. So what we would love to see more is the government continue to incentivize AI governance, as per recently, like the finalized Office of Civil Rights rule. We'd also love to see that continue to set baseline standards such as transparency requirements, like we've seen with the ONC requirements and with FDA's transparency principles. Finally, we'd love to see more funding for governance tools and workforce training. When it comes to developers, we'd love to see more standardized information disclosure, including checklists, so that they're sharing the same information that's needed for AI governance with each health system. We'd also love to see them work closely with health systems in order to align expectations. And on the other side, what we've also seen is developers are developing tools to help facilitate governance, such as tools that help to detect bias. And as I move to health systems, I do want to emphasize that some health systems fall into both of these buckets. They're developing their own tools, and of course, they're systems who are looking to build up their AI governance, they're learning from their peers in this space. And finally, in terms of additional actions that stakeholders can take overall, we'd love to see additional governance codes of conduct being released, as well as we're encouraged by work on third-party insurance labs and guides that are being released in this space. So that brings me to the end of my presentation. I'm really excited to hear the discussion for today. And I think I'm going to pass it back to Christina. Christina?
Val, thank you so much for that great piece of level setting. And we're going to be continuing to build on that conversation throughout the meeting. So I'm going to introduce my colleague who will be moderating the next session, Nicoletta Economou, Director of the Duke Health AI Evaluation and Governance Program. Nicoletta?
Hello. Thank you, Val and Christina, for the excellent work. I'd like to welcome all of you to our fireside chat, where we'll expand on the topics of tailoring approaches to AI governance, benefits, and lessons learned. And first of all, I would like to introduce you to our speakers that have joined us here today, which are Bridget Ojeda, System Vice President, Chief Information Officer at Bryan Health, and Lauren Roast, Senior AI Machine Learning Engineer at Mayo Clinic, who's heavily involved in their AI governance at Mayo. Thank you for joining me, Bridget and Lauren. So, and my name is Nicoletta Economou from Duke University, and I serve as the director of our ABC's oversight process here at Duke that essentially oversees, governs, evaluates, and monitors all algorithms, including AI, that are used for patient care. And Duke Health serves as the North Carolina population. We have 3 main hospitals that are in Durham and the Raleigh area. And then we have primary care and outpatient and specialty services that extend throughout the state. We're an academic medical center, as you could imagine, combining the health system with the Duke University School of Medicine, School of Nursing. And our governance process that we have is overseeing not only internally developed solutions, AI solutions, but also those that are procured, from third parties, developer organizations, how I like to call them. And then, or some that might be co-developed with third parties. So I wanted to open it up to both of you to understand better a little bit about your governance process, because I think there's different diversity, if you will, in the AI governance structures that we might have across the nation. And so we, for example, at Duke have a more centralized, if you will, way of performing our governance. So we have an inventory for all algorithms that we have. We have a registration process in order to understand bare minimum information about what AI solutions may be coming intended for patient use or already in use in our healthcare system. And then we have a committee with diverse stakeholders that, a subset of this committee actually performs the review of in order to ensure that our AI solutions that we're using for patient care are fair and equitable, are safe, are of great benefits to our patients or to our clinical workflows, and we make go no go decisions right throughout the life cycle of our tools. How are you doing AI governance in your organizations? And perhaps we'll start off with Lauren, and then we'll have more input from Bridget.
Perfect. Yeah, thank you so much, Nicoletta. So at Mayo Clinic, we found that we would bring our AI subject matter expertise to support the existing clinical governance processes. So we took the approach that because it's an AI solution, we didn't want to break down our existing processes. So we augment to bring AI subject matter expertise to the clinical review process and to the governance process. So that we can support with critically evaluating the AI tool given a background of AI subject matter expertise. So we take a similar parallel with supporting our colleagues in IRB as well. And so we've also, coming from AI enablement within Mayo Clinic, we help to take an enablement and consultation approach to governance. So we kind of separate those functions where we can support with consultation, help the teams to provide the documentation to support AI best practices, that their product is safe, effective, and ethical. And so we have found within Mayo Clinic that we can still have this kind of enablement model to support our colleagues in governance and also support our innovators.
Bridget, what are you doing at Bryan Health? And please tell us a little bit more about your organization as well.
Thank you, Nicoletta. Yes, Bryan Health is in the heart of America in Nebraska. And so we have a very rural population that we get the privilege to serve. We are a 6-bed hospital in the southeast corner of Nebraska and then going into central Nebraska. So are very important for us to have a good structure put in place to support our AI initiatives as we work across the state of Nebraska, serving populations in rural health. So we decided to put our AI governance structure within our IT governance structure that we already had in place. And so establishing it under an existing model allowed us to use a lot of the workflows and processes that were in place, such as the intake process and using a good registry for AI tools. So a lot of the same methodology that we could build from our IT governance and our data governance structures overlaid and played well into our AI governance structure.
Lovely. So it sounds like Mayo and Duke actually have created off the ground kind of like their AI governance, which has one makes go no go decisions, the other one is more kind of like a collaboration with the project teams. We also kind of like collaborate in the way that we have consultations for our project teams and then help them kind of like understand, you know, what our principles are and how those could be met as well. But then Bryan Health actually leveraged their existing IT governance structure and then educated those within that governance, that existing governance structure around AI, right? In order to actually meet the needs of these ever-evolving AI technologies coming into the hands of our clinicians and impacting our patients. So it's really fascinating to see kind of like this diversification, if you will, of how we're implementing AI governance. What do you think, and because you have been part of this journey of putting and setting up these AI governance in your organizations, what do you think have been the benefits of these efforts and the drivers of success of implementing these governance structures?
I'll go first. So one of the biggest drivers benefits, first and foremost for us, since we do both the patient-facing AI and then the support services side of AI, it was important for us to get a cross-organizational representation from clinical leaders, finance, legal, IT, physicians, etc. And this helped us so that we were able to make really well-rounded decision-making. Our first and foremost thing, as you mentioned, Nicoletta, was to get this group educated on what their expectation and roles were for selecting and then maintaining AI tools that we bring in. One of the biggest benefits too was, as Valerie mentioned, our standard implementation process or model that we've tried using so far, and it's played well for us, is running our model silently in the background, collecting that data, then turning it over to operations with a data scientist to make sure that the algorithm is meeting the needs of our population. We are typically not a developing shop, so we grab tools that are already out there from vendors and then make those models work for our population. A great example example of kind of a lesson learned from that experience was we had selected a model and put it towards a patient population just to learn to come to find out that the patient population that we had selected was too large of a diverse of a population. So making sure when you do put an AI tool in that it is specific to the patient population that you're selecting, whether the patient population is for a specialty group or a family practice, that you're paying attention to that patient population.
I really like that. Yeah, I think, Bridget, to your point about silent evaluation and turning tools on to monitor performance, I think that's also another benefit of AI governance that we see within Mayo Clinic too, to kind of engender this culture of best practices. So what are our expectations for innovative tools, and how can we help socialize these expectations and support our innovators to reach these kinds of expectations too? So some other benefits that we've found too is having an inventory allows us to understand and set precedent for to allow for reproducible and efficient future reviews and predictable pathways for our innovators too, to understand what does bringing models through the AI lifecycle at Mayo Clinic look like. Also, governance can allow us to break down silos, so we can democratize the information. So that way we can be efficient with our resource capabilities. So for example, there might be multiple tools for discharge prediction or readmission from our different vendors, for example. And so how can we help to be really efficient with our resources and perhaps connect internal innovators too to what are some different activities going on? How can we partner together? And then just circling back to that kind of culture of best practices, that we can bridge this culture of product development with software development lifecycle best practices with a culture of patient safety and patient care. So how can we bridge these risk thresholds between these two different contexts?
Excellent. Yeah, so bringing, and I'm hearing like a theme, right, of, educating and these cross-disciplinary, if you will, projects, right, to implement AI in your organization. You have a clinician that may not understand what, best practices for like deploying, testing, and a software really would be. And then you have the actual data science piece of like an algorithm performing or not performing well, and how can the clinician test on their side, right, if what performance means to them and what benefit means to them, right? So really creating that interdisciplinary cross-section that I think is reflected then on the AI governance committees themselves, where you need to ensure that, you can independently evaluate some of these solutions as an organization effectively, right? And just like an example of, this culture of excellence, if you will, or of high quality for our patients, was when we became aware of an FDA cleared technology, but then now the clinicians in the clinical departments, just by testing the tool, really unraveled that this solution actually was not performing appropriately. And there was a calibration of an instrument that needed to be done in order to actually measure appropriately and have the AI algorithm perform appropriately. So this kind of itch, if you will, of testing and asking the question if it's meeting its intended purpose is actually, if you will, augmented by having AI governance in place in order to establish the bar, right? So I think that's fascinating. And then when it comes to, I don't know if in your organizations, you've also encountered something similar, but when it comes to fairness, to equity, right? I think at least when we started off our AI governance journey, there were no like clear guidance or for how you would establish, right, how for your patients you would want to ensure that they're being provided care in a fair and equitable way. And so do you think that your AI governance structure enabled you to actually perform that appropriately? I'll pick on Lauren here. But do you think that AI governance was essentially that Trojan horse that enabled you to also look at that angle, not only safety, but fairness and equity for your patients?
Definitely. I think AI governance allowed us to have that mechanism of, like you said, have a kind of expectation of center of excellence. How do we socialize especially in this innovative forefront where, expectations are changing. So how do we have a pathway towards keeping up with these changing standards and recommendations? So yeah, we have definitely, through the huge help of our AI ethicist, Dr. Momin Malik, who is with us, we have been able to kind of have this mechanism of what are expectations and best practices for health equity as it pertains to these AI models that we're deploying.
And for example, like we saw that some peer-reviewed, if you will, from journals, algorithms before out the formation of our governance structure, we're not asking key questions around kind of like some of what I like to call sensitive variables, like sociodemographic variables or whatnot, feeding into models where perhaps it wasn't needed. And so, Bridget, I don't know if you have anything else as part of a learning that you wanted to share in that regard.
Yeah, I think you're absolutely correct, Nicoletta, is that's why we do run these silently in the background, because to your point, these algorithms are typically created on a patient population that may not be your patient population. For example, being in Nebraska, a patient population in, say, Florida aren't the same demographic patient needs. And so what does that look like in making sure that we do have a data scientist who ensures that data and that algorithm predictability is truly meeting the prediction on the patient population we're serving?
And then also, I do think that, I'm hearing from both of you that now organizational transparency into what algorithms are running where and how they're performing and how they're actually impacting care is something that is of great benefit, right? To actually standing up an AI governance structure like this. Do you also think that and we heard from Lauren that also kind of like having an inventory is that first step, right? In order to ensure that you have an understanding, quite frankly, of what exists and what is running, because sometimes within the organization itself, there could be silos, and you may not know, like in different departments, what algorithms are used and when. But when it comes to, I don't know if you wanted to share anything around any other benefits, but when it comes to scalability or business continuity, were there any benefits that you saw in your health system when you were that you were made aware of because of your AI governance, your involvement in your AI governance structure?
One, I think discovering that there were AI tools out there that we didn't know existed. So really pulling that registry together. And what that has allowed us to do then is to take that registry and build a feedback loop into the AI governance program. Taking that step lower is just having that list and then scheduling out throughout the year when that operational owner and developer will come back to the committee to do a routine check-in on how their algorithms are running has been really important for us to really get down on a accountability level and ensuring that we know what's going on out there. Overall, I think the repetition and consistent exposure of our governance committee is starting to really get traction in building understanding of our operational folks to build in that accountability of these tools that we're bringing in.
Yeah, yeah. Identifying, right? Like who's responsible for each individual tool, right? Like establishing the business owner, clinical owner, right? And the actual model owner or technology owner. That's essential, right? Like we do it during our registration process, but I see you nodding, Lauren. Um,
Yes, yes. In terms of, yeah, responsibility and business continuity too, I think another aspect of that is how do we scale in terms of our risk analyses too? So how do we learn as we go the different profiles and use cases of these AI tools? So that way we can have scalability of our risks. So what is the risk library that we can associate with a certain tool to kind of expedite not only for the innovator, but also for our internal group doing evaluation and our governance groups. And it also allows for traceability of risks and transparency for our innovators too. So how can our innovators be aware of certain risks that are associated with their tool so they can put the certain risk mitigations in place as they move through the AI lifecycle? And so we can pull off of course, building off this foundation of different literature existing and regulations and standards and laws. So that way we can scale and have this kind of business continuity as well. So that way we can innovate as we move forward and as we institute and support governance.
Absolutely. And then I wanted to dive in a little bit more on lessons learned, right? Kind of while you were setting up your AI governance structures. So, coming from the clinical trials industry, if you will, there was a lot that, I was able to see that you could kind of like translate from like quality management system, right? When it comes to how you could even think about the oversight of some of these algorithms. And health systems are not, if you will, kind of built, right, to do kind of like this product management piece. So that was a quite apparent learning, I think, just thinking about AI governance and, sometimes when those are kind of internally developed or procured, right, because it's not like any other software. Here we're talking about AI, so it is, Bridget, to your point about also, ensuring that it's working for the patients that you serve. You need to do that local testing. And there's a question from the audience on, that's relevant as well that I'm hoping that we can get to. So, and I wanted to ask you, for us, it was a top-down and bottom-up approach that, it was essential to learn together, especially in the beginning when we didn't have the regulations for software as a medical device, um, from the FDA in order to say what's regulated or not regulated by the FDA. I wanted to ask you, what were some lessons learned on your end? Because I think we have tried to strike the right balance between innovation and high quality care and ethics. And the current state going from, in order to kind of like ensure that, quality and ethics is, something that is of front of mind for our workforce, if you will, was a culture shift, right? And you need to work, as you said, Lauren, collaboratively with project teams, especially in lieu of any regulation, right? In order to, in the end, make sure that you're doing the right thing for your patients. But any other lessons learned that you would like to share?
Sure, yeah. I would similarly, Nicoletta, I would echo that point of just like how do we speak the same language? How do we come to a shared understanding and risk frameworks and risk thresholds to kind of bridge this world of product development and patient care? So we're all coming together in bringing our expertise and perspectives to meet the needs of our patients, while also standing and supporting governance through these regulations. I think another major lesson learned there too is, like you said as well, how do we have consultation and enablement in an architecture and environment of governance? So a major learning that we've had is having navigators and consultants that help our innovators move through the AI lifecycle, because this AI lifecycle is not intuitive. As you move through the life cycle, you gain a lot of knowledge, but how can we democratize these learnings to speed up our innovators so that way they can learn through different common pitfalls? So how can we raise those as navigators, as consultants, as enablers to support them in developing the documentation to show that their model is safe, effective, and ethical? And so that's kind of like the spirit of our main lessons learned, is really how do we bring AI subject matter expertise to support governance and also support our innovators. So we want to enable our existing domains and augment our existing really strong existing governance processes. And then that also allows us to align risk across the enterprise. So how do we have a shared understanding of risk across our software reviewers and security and privacy and IRB? How do we move to come together to have this shared understanding of what is the risk level for this particular use case or digital health technology?
Wonderful. Bridget, would you like to chime in?
Of course. I believe too, another area that one is making sure that the problem that the AI tool right up front is that you have that clarity piece established with operations, the requester for the new tool, to ensure that it's solving for a problem that we actually have, and it's not that new shiny idea or tool out there, and it becomes and it's hard to put a lot of energy around that because there's such a demand right now. And so I think this governance team has allowed us a good way to assist operations with prioritization of these coming in and making sure that there's clarity around the problem up front that we're trying to solve for as well.
I love it. So it really is that matchmaking, right, of the need,
Mhm.
that need within your organization with the appropriate tool, which may not be the case, but and chaperoning, right? Like, and prioritizing based on your strategic priorities, which one should come through first, because resources need to be allocated beyond the cost of the tool in order to ensure that they're basically run ethically and responsibly, right? In your organization. So I'm going to go to questions briefly because we have a little bit of time. And the first one is coming in for Bridget. Well, there are two that I'll try to summarize. Um, and Bridget, when the different AI tools are evaluated, who evaluates them, and what are the key differentiators you look for, since there's lack of transparency, governance, and the minimum size of the training data and the size of the test data sets when AI tools are developed? And then in a very similar fashion, there was one that came in about, could you share more about the patient population being too diverse? What did you see in the results of the tool that demonstrated was effective? And I think those are very relevant questions.
Yeah, great question. So first and foremost is the evaluation process of the tool. We have a inpatient, so we'll take a tool that's going to be used on a nursing unit per se. So we have an inpatient work group that would first evaluate whether that's where we're going to spend our energy. And if they agree, yes, we love the idea and the concept, they then move that forward into our data analytics AI governance team to really get down onto the deep dive review of that. Is this going to be a good partner? We have a questionnaire that we provide to our vendors and really get down on that next level. So that's kind of the selection process up front from it. Moving into the patient population side being too diverse, the algorithm in this particular scenario that I was talking about was for family practice, the algorithm was based on family practice patients. We had included all of our ambulatory space patient population. What happened in this scenario is it picked up specialties and specialties such as podiatry and pulmonology, et cetera. That patient population had a different needs. So the AI algorithm, when we looked at its accuracy, it completely was no longer valid just because the patient population we had selected was too diverse, and that is not what the developer of that particular predictive model had used to build the algorithm. So it does make a huge difference on if the developer developed it for a unique case of patients, to make sure when you put that into production that you're also trying to use it. Otherwise, you're going to have to rewrite it and develop the patient predictive model off of that bigger patient population. I hope that answered your question.
Yeah, and that for me underscores the need for us to look carefully at, also those algorithms that are used for what we call standard of care, but they might be based on medical guidance, right? But they might be like EGFR. It's a data-driven tool. It actually is not a clinical consensus model. So how do you actually ensure? So it's, those clinicians bringing it in should actually be thinking about, their patient population as and testing it before they deploy it, and not like closing, if you will, our eyes and ears and just blindly deploying them and programming them into our interfaces, right, to be used for patient care. Lauren, we have a question for you. Could you speak more about your risk library and what does that look like in practice?
Yes, definitely. So this is a developing area for us where we are building out our risk library in terms of technical risks, patient risks, regulatory risks, risks to the users, to providers as well. And so, for example, to give some examples of each of these areas, for a technical risk, we are looking at, will this tool be able to withstand the throughput of users? Will this tool be able to bring a model output to the user interface in real time? So also for some patient risks as well. So what is the clinical setting where this tool will be used? Will it be in a really time-sensitive environment like the ER? And then what else, or ED? And then what also is the nature of this clinical diagnosis that the tool is addressing? So also some regulatory risks as well. We want to know about the possible regulatory determination of the tool. So will this likely be a medical device or not? What is the level of risk associated in terms of the regulatory space? So we have a large library of risks for each of these different areas of purview. Those are a few examples of the different risks that we look at. And we classify for this risk library, what are certain risks associated with certain use cases, so that way we can have reproducibility and traceability to be able to scale our risk reviews.
Perfect. We also have a risk assessment that we perform once we get the registration information, so that we can either like do a very rigorous review or what we call fast track, right? Like actually we define the rigorous review based on the level of risk to the organization and the patients. So one last quick piece of advice that you would give other health systems embarking on this effort of setting up their AI governance. Bridget.
I would say that it's a journey and you need to start somewhere and it'll continue to evolve. and making sure that the team that you select to be on this committee is really agile and adaptable, because as the AI technologies change and our regulations change, this team will have to be really iterative and agile. So that would probably be my speed round advice for anybody looking to start a AI governance program.
Amazing. Lauren?
I really like that, Bridget. I think that's a great point, to be really agile, multidisciplinary, to make sure all of the different stakeholders have representation. And in order to be agile with this changing state, we need this spirit of collaboration and enablement, so that way we can support both groups. That's kind of what we've learned and what we advocate for at Mayo.
And so I think, AI governance structures will need to evolve, especially as we see these AI methodologies also evolve. And that I think we truly do believe that AI is here and it could potentially help solve a lot of problems that we're facing right now in patient care, clinician burnout right now, or perhaps help us with detect and improve clinical diagnoses. But I do think that having organizational transparency, right, will also, and having AI governance will help us ensure that we're delivering the best care for our patients. So thank you for the interesting conversation. I can't thank you enough, and robust conversation. I'll now hand it off to Christina, who'll be moderating our next session.
Thank you so much, Nicoletta, Bridget, Lauren. What a fabulous conversation. I'm so happy that I was able to listen into that. We are going to be moving on to our next session, where we're hopefully going to build a little bit on some of the questions that we got, really around how do we democratize AI governance. So we just heard from 3 health systems that have put together an AI governance, but I know that a lot of health systems are having troubles with it. So before we begin, I want to introduce our speakers. I'm joined today by Laura Adams, Senior Advisor in the National Academy of Medicine, Maya Hightower, CEO and co-founder of Equality AI, Randall Ruda, CEO of the National Health Council, and Jennifer Stoll, Chief Executive Affairs Officer of OCHIN. Thank you guys so much for joining us. So Laura, just as I kind of started to talk about right before I did the introductions, I know you've been talking to a lot of different health systems about AI governance, and I would love to hear where you see some of the commonalities and approaches, and where you're seeing some differences.
Yeah, it's a delight to be with all of you today. I always learn so much from these, and this is no exception. That was such a rich discussion that went before this. I have been spending some time out in the field, because most Americans, of course, get their care outside of academic medical centers and the large academic, the metro hospitals areas. So I really wanted to see kind of on the ground and visit on site with board, senior leadership teams, and clinical leadership teams kind of all across the country. So I visited places in Kentucky and Florida and Nebraska with Bridget's group, and Indiana, California, across the country, so I could get a sense of how are they thinking about this and how are they implementing it. And it was really eye-opening, encouraging in many ways. So the commonalities that I saw are that people really are grounding this in their mission, vision, values, their organizational priorities. There's an extraordinarily thoughtful approach being taken to this that I think is distinct from an implementation of things that we've done with digital health in the past. I think we've kind of just done that. So everybody wants to ensure the safety, privacy, security, effectiveness, ethics, and equity of their use of AI, which to me is, of course, the framework and the grounding set of principles. And I'm seeing them being remarkably consistent across the country, which I feel is something very positive to celebrate. I think that'll help us to learn more from each other, since we've got a similar set of guiding frameworks. I'm seeing that multidisciplinary approach, but it varies. Depending too on the resources the organization has. So obviously the developers are there, the clinical leaders are there, the administrative leaders are there, not so much the patients there so much, not so much ethics people. Some don't have ethics people on staff. Interesting and creative solutions to that, where they're seeking from their communities to see if they can bring people in. Now, lack of exposure to what goes on in the health system setting is a little bit challenging, but I thought it was creative. And some are including their QI and workforce redesign teams in this because they recognize the importance of being able to make sure that these are seamlessly fit into the settings in which they're introduced. So the other thing that I've noticed is that all are implementing AI, and nobody's waiting for their governance structure to be completely built, baked, done. They're going. Some of the varying approaches that I've seen, I saw them similar to what that was reported in your excellent report, which, by the way, I work with a group called the Governance Institute, which has as its members all across the country, medium to smaller size health systems. And I'm going to make sure that there is broad distribution of that report among that group. One of the things that I saw from a couple of sites that I visited is they're putting a temporary ad hoc team into place because they just feel somewhat unsure about this. So they don't want to sort of designate it. The deliverables of those groups are for their governance framework. So what do they recommend that the permanent governance framework look like? Roles, responsibilities, interim policies and procedures, particularly for the kind of immediate governance needs, ethical review, data quality, security. The framework for evaluating their initiatives, I'm excited to see that. I think all of us are recognizing that no matter how much testing or assurance has gone on prior to implementation, we really have to become much better at understanding whether what we do works and how it's working in our environments. Recommendations for permanent governance, detailed proposals, and then last, a risk assessment report. So another couple of unique ones that I'll just comment on is Providence, based in Washington, has a very unique structure. Dr. Hoda Asmar is their chief clinical officer there, and they have a generative AI leadership council. They put something distinct together for generative AI. They have 3 groups that they have brought in to inform that council. Those groups are AI guardrails groups, the information protection groups, and then the data ethics groups that they inform that. And then they have 4 subject matter expert groups. You might expect that that's the clinical, the patient and their consumer work groups, their workforce, and their back office and administration. So just to close out on this, I did see 1 or 2 who are really beginning to focus on becoming co-developers in the future, which surprised me. And they're starting to develop innovation centers where they think the use of their data is going to be very valuable in the future. They want to be able to develop algorithms that'll be used by others like them in terms of their health system size, characteristics, profiles, and so forth. And they're really thinking innovatively about establishing these innovation centers and what it might look like to think about commercializing their AI algorithms, which was kind of news to me. So I would just close out by saying that the how to engage patients, how to engage ethicists, things like that, I think is really an open question. And we're really not finding that we have much experience in this arena, which to me signals something new and valuable coming out of AI, that we're thinking about this really in detail now, how to implement it. I would just let you know that the National Academy of Medicine's AI Code of Conduct capstone publication will be coming out in 2025. We spent 6 months with developers, researchers, health systems, federal agency representatives, patients, equity and ethics experts, and quality and safety experts to say, what are the behaviors that we should see from each one of those stakeholder groups vis-a-vis the others? So if you are a developer, how do you engage all of those that I just listed? What is the role and responsibility? So there's a big section in that paper coming out that will give us much more detail about the viewpoints of these. And there were certainly Mayo representatives on that. And also I learned a lot from Nebraska as well in Bridget's group, and that's reflected in it as well.
Thank you so much, Laura. I know I think it's been so interesting, and I've had the privilege of talking to several health systems as well, and it really does echo what Bridget said at the end of last session, which is it's a journey. I don't think anybody I talked to felt like they were done. They figured it out, and they were just going to keep moving. So I think that idea of let's just get started, particularly if you are implementing AI, is so important. I want to turn to Jen. OSHA works really closely with a lot of under-resourced health systems, and AI expertise is just not necessarily going to be there. How do government and other stakeholders help these systems share in the potential of AI?
Yeah, thank you, Christina. And for those of you that don't know who OCHIN is, we are a national not-for-profit, and we do health information technology in rural and underserved communities across the country. And we support about 7 million patients that are actively being seen. And our part of the delivery system is the most rural and underserved part of the delivery system. We support federally qualified health centers, critical access hospitals, public health departments, especially mental health providers, homeless service agencies. And so, when we think about AI as a partner in supporting over 300 unique safety net providers across the country, one of the first things that we think about are the infrastructures that they have in place. One of the concerns we have is that right now, if you don't have good foundational infrastructure in your technology systems, you will be left behind from this opportunity to really drive innovation, efficiency, reduce provider burden, all the hopes and dreams that we have for AI. If you have not a great system in place, you are going to have disparities between those that can really participate and grow and change and be part of this conversation. And we've forgotten that meaningful use programs actually helped adopt EHRs years and years ago, but many were left behind out of that. And you can see the disparities between who has good systems and who are participating and who haven't. So as we think about this, we think about, do we have really good basic infrastructure in place? Do you have high quality systems? Do you have staff that even understand what AI is? I mean, and that's one of the biggest challenges that we see too, is having an educated workforce that and a workforce that understands and can keep up with the intricacies of AI when they're on systems that they are retrofitting to just try to get by day to day. It's not uncommon for us to support a critical access hospital when we go in to help modernize their system where they're on 3 disparate EHRs and they dropped a paper for surgery. So, to think about getting them into a place where they can actually drive AI systems. I mean, we're talking about full sprint versus I'm basically walking or crawling to get to another place. So being able to still allow for those that have that need the investment and the support to get up on EHRs and supporting programs like what the USDA is doing around rural development, things like that, I think are really important. And then having the right workforce. Regarding AI governance structure, we do believe that for our section of the delivery system, that local validation is going to be really, really important. We can set national guides and structures in place, and that is absolutely, guardrails are absolutely critical. And local validation is also key. And as an example, we are doing a lot at OCHIN to teach some large language models Spanish, right? They don't understand the world that we live in, or the chart notes that come back or the patient emails are very much out of the reach for a lot of our patients in terms of the education level. So we're teaching many models how to bullet point, how to write in a 5th grade education. So being able to have government partners that understand that, to really have a model work, while there's framework nationally, we need to have local validation as key. So hopefully that's helpful.
It's so helpful. And I when I think about the potential of AI, what Nicoletta talked about at the end, it's ironic to me that the people that could benefit the most are going to be the ones who don't necessarily have the resources to actually implement it safely. And I think that that's why this democratizing movement is so critical, because in a lot of these spaces where there's just so much burden, which limits access, being able to build in these efficiency tools could have a real difference, and make those systems be able to be much more responsive. So thank you so much. Randy, I wanted to talk to you too, kind of talking about patients. I did want to ask you, how are patients feeling right now about AI tools and health systems? And is governments potentially going to help them build trust in those systems?
Christina, that's a great question. And I'm so encouraged by hearing the other presenters today really speak to the concerns, observations, the work that they're doing, because I think in large part that will help patients and the patient community have a greater sense of confidence just because of the way these issues are being addressed. And there's such a sincere interest on moving forward. You asked me to participate. So the National Health Council has 200 national organizations dedicated to health. More than half of our members are patient organizations themselves, from large patient organizations like American Cancer Society and the Heart Association, to lupus, arthritis, Crohn's, to smaller rare disease communities, and those providers, including these systems around those patients, all dedicated to helping patients lead the most healthful lives that they can, and how the system can really be supportive. So it's interesting, to answer your question specifically, so how are patients feeling? Well, when we do polling, and it's different sets of patients about AI, one, it's still a learning process. There's so much that's unknown within the community. That's even true within the patient organizations themselves. It's about 50-50 in terms of, do I feel trepidation about what I don't know, and then am concerned about, the safety of my information, the misinformation that might occur, the challenges within the current system where maybe the information that an algorithm should draw from for a particular patient just isn't in the data set because they're from a marginalized community, a minority community, a community that's not typically contributing to some of the data that then the algorithms draw from. And in the same way, they're also excited about what this could mean for their personal health. I mean, could AI have them a better experience in their healthcare? More face-to-face eye contact time with their clinician because of ambient listening and ways in which that clinician doesn't have to be taking notes, or maybe clinical decision-making that could help their clinician in whatever setting benefit from the best knowledge that's out there. Of course, it would have to draw from the right data set, right? But patients, they care about their health and their families around them. So when we say patients, it's really patients and caregivers and everyone who's involved in that episode of care, whether it's an acute episode, or for many of the people we represent, chronic conditions that they're managing over the course of a lifetime. So for them, it's this, I'm concerned about safety. I'm concerned about being able to trust the system. There's a lot of concern about whether data in the system might be used not necessarily for their best health outcomes, but could actually be used against them. It's not so long ago that people that are served by my members weren't affected by pre-existing condition discriminations, information that flows up to their employer that could affect their employability. So that those concerns are in the background. But that other 50%, sometimes that's represented in the same person, also sees the potential for better care that's in best practice, that's informing their clinicians. They're also looking at ways in which some of those gaps in the current data set could be improved, or how they might have an opportunity to participate in clinical trials and bring their information forward for the greater good. And so that's kind of that personal journey that patients bring to this conversation. And so much of what's been discussed here really creates hope, I think, for those patients. On the patient organization side, our members themselves, they're really trying to be up to speed and really trying to help be good advocates and good partners to their patients in the systems like we're talking about here. So as we talk about governance committees, as we talk about, those committees or councils that typically engage patients, let's make sure that the patient organizations in your community that are organized to best represent and include patients, that are trusted messengers to the patient community, let's make sure we're leveraging those individuals to have their help, their partnership in taking all of our goals forward. And for patients in this setting in particular, not AI setting, but just in healthcare generally, governance structures, including those kinds of models that might come from the federal government, from state government, from clinical societies and things like that, they see that as offering protection. And so I think the extent to which these governance models can emerge that just show that we've got your back, that's going to be critical. And also paying attention to any place in which some of this patient data, including patient data that sits within our own patient organizations. There are millions of patients that are in registries and rich databases that could obviously be leveraged in this space. Let's make sure the governance structures can draw from that. And I think we're going to be really excited about the progress we can make. At the end of the day, I think for people, certainly at the organizational level and for more patients that get exposure, they see AI as an opportunity to improve their own personal health journey and maybe right some of the challenges that have existed in our systems, mostly around disparity and equity, to truly have a better system that serves them and the community at large.
Thank you so much. And I'm glad to hear that. Well, I mean, to be honest, 50-50, that's kind of what I feel too. I think that, it's a unique opportunity to bring in the patient voice. I often use this example. Hospitals have never asked patients whether they should buy a new MRI machine or not before. But I think that this is a space where it makes sense. And so we do need to build up those avenues of communication.
Just to respond to that, Christina, and I know we'll move on. I think this is an area where health systems can really distinguish themselves. I think the leadership that I'm hearing on this call could really set the stage in a way that patients would say, well, I'm happy that my care is provided by that system or was informed by the system experiences you're describing. This is an opportunity, I think, for everyone to feel better about our healthcare system, both at the community level and nationally. And just know that the patient organizations, our organization is all in to be a partner in that.
Thank you so much.
Mhm.
Maya, excuse me. I'm turning to you. I'm really interested in understanding kind of your thoughts in this space, and particularly one of the things that might help democratize AI governance is just to make it easier. And so I'm wondering if you have any thoughts around tools or resources that can make the AI governance more manageable, potentially maybe in terms of performance drift or bias detection, things like that.
Yeah, that's a great question, because you're absolutely right. One of the big challenges is making the pragmatic approach to making the AI governance process accessible to all health systems. And unfortunately, there are no easy, say, management tool. There isn't an AI governance in a box concept yet that we can really disseminate widely, that doesn't require a significant amount of resource as well as upskilling of workforce in order to make it happen. But I do think it's important, from the lessons learned earlier in this conversation, about starting pragmatically with what you already know or what your organization already has capabilities in when it comes to governance broadly. And so starting especially with data governance and application governance being key competencies in AI governance. There's a lot of overlap and a lot of tools that your health system may already have in place when it comes to application governance and data governance. And so repurposing a lot of those tools and processes, and then identifying where the gaps are when it's specifically with AI governance. And when it comes to identifying those gaps, it's picking a framework, right? Like, how do you identify what the best practices are? It's by pragmatically picking a framework. And there are now emerging frameworks, whether it's international frameworks like ISO's 42001, AI management framework, that's like big international framework. Nationally, it's NIST's AI risk management framework, which is a great framework that is industry agnostic for healthcare industry specific. I know National Academy of Medicine has a great Bill of Rights, as well as when it comes to CHI, which is a Coalition for Health AI, has recently come out with a detailed framework. But sometimes with these frameworks, they can be overwhelming. They have hundreds of capabilities. But I do think, again, starting pragmatically and breaking it down to what are these frameworks really actually targeting. So for example, NIST, you can actually break it down to 4 main competency areas: mapping, measuring, monitoring, and governing. And so mapping, the earlier panelists had talked about the importance of having that inventory of AI, whether it's algorithms or applications that contain algorithms, and then being able to measuring on silent, right? And then using different other, say, maybe regulatory frameworks like ONC's HTI1, which is AI transparency, where it's really focusing on when you're measuring the demographic representativeness of the training data set that particular model was developed, and how does that apply to your patient population? Again, concretely described by Bridget at Bryan Health, and then making sure that you're doing that stratified performance. So these don't necessarily require special skills like toolkits or something around AI evaluation, but it's just like, okay, how does that model perform against my population, stratified by those different demographic groups that are important for your transparency. And then that monitoring capability, doing it, maybe it's annual. Right? Again, Bridget had a great example of an annual review process where you're bringing back those metrics and then governing and deciding, do you move forward? How do you optimize? And so I think that there isn't, again, an easy button there, but there are a lot of different tools when it comes to bias detection specifically. The tools do still require a significant amount of sophistication, right? Especially when you're getting to AI evaluation methods for bias detection and mitigation. For predictive models, you've got, Google's got a Fair AI. They've got IBM and Microsoft. There's a lot of different open source toolkits. We have an open source toolkit as well. And that's a good start to at least just play around. But I do think that those are skills that you build up to. Day one, you don't have to start doing fairness and bias detection and mitigation. But even if you start off with just the measurement part around, your demographic representativeness, running it on silent, seeing how it performs against your population stratified by demographic groups, then you're in a great place. And then playing around with these fairness metrics. And the AI evaluation, when it comes to Gen AI, we actually don't have really good scalable tools yet. So fortunately, that's still in the works. We do have some, QI sort of every day. There's great papers on how different health systems are approaching it. Some of which are replicable, and some of them are even as simple as scoring mechanism. Like, okay, how well did it perform 1 through 5, to more sophisticated evaluation methods. So that's still evolving, but I do think, again, advanced skill set, you don't necessarily need to implement it day one, just like you don't need to implement a whole NIST AI risk management framework day one, but start with those 4 main buckets.
The journey. I like how we keep coming back to the fact that it's a journey. So I have an audience question, actually. For smaller or resource-strapped health systems that may not have the capacity to perform all governance-related tasks in-house, are there components that can be achieved through external vendor partners? And what advice would you give some of these health systems about how to approach the possibilities and realities of AI? And you kind of already got to that a little bit.
Exactly. Absolutely, there are definitely vendors in there that are happy to help. Some are affordable, others are, your PwC, your big consulting firms. So there is an emerging, growing market of those that are happy to help. And for that matter, healthcare, health partners AI, right? So yes, you at Duke, and I think as well, Jennifer Ochin, and there are others that are part of these nonprofit efforts at helping health systems be able to evaluate without having the full governance capabilities.
And did you want to jump in too?
Yeah, I think it's important to also understand is that I don't know if it's widely known that AI is really different software from many of the other tools that a lot of small practices or under-resourced providers are deploying. And to that end, that there is tremendous responsibility on the deployer of the tools at the end of the day. And I think it's important to emphasize that they just don't have the capacity, if something were to go wrong, to navigate that. You're talking about providers that are, maybe 20, 25 days cash on hand, and, otherwise they'll shut their doors. And so, and we need to be able to have networks and partnerships that allow safety in numbers to be able to support this work, and be able to, going back to the question that you asked earlier, Christina, about what the government can do, is recognizing that representative data and then being able to have local testing validation is really key to also be able to protect those that are deploying these resources. So some sort of liability protection, I think, is really important. And for the provider or the deployer, especially if they just don't have the capabilities to build out their own assurance labs locally. I think this is one of the big pieces that we see is the ability to be able to say, okay, in the 7 million patients that Ocean has, how do these things perform? And then be able to test locally and then manage the maturity on the back end, and be able to provide that comfort and that safety for our individual members to know that these tools, to the extent that we have seen today, are I don't want to say safe, but provides some sort of trust around this. I mean, trust is going to be key. And how do we put systems in place that build that trust to be able to take advantage of the revolution that AI can provide to really, as I said, support the section of the delivery system that's most under-resourced.
Thank you. Laura, Randy, do you have any thoughts on this topic? And not only that, but also what Jen kind of hit towards the end of what can the government do?
Well, I'll just jump in, although I take a lot of my advice and direction from Laura, so I'll look forward to her remarks when she speaks next. But I think I would just call attention to the fact that view the patient community holistically. It's not just someone seeking assistance with a health challenge in the system itself, but it's as an advocate, as a partner that can join health systems and the larger health systems community in arguing for those kinds of supports. And so, Laura and Nicoletta have been really helping us understand the principles that we're adopting can be used by all of our patient organizations in their advocacy, in their work with the investment community, in their work with providers, clinicians and others, to really be an advocate for the investment in the governance part and AI generally. So I think what we're talking about here, just know that the patient organizations, because they're the organized part of the patient community, should be viewed as holistic partners that can stand side by side on a policy change, on an investment change. I think we will have opportunity for that, and know that we're doing our best to mobilize that community and provide kind of the language and the understanding to make the patient community fully a full partner in all of these efforts.
Yeah, I would add to this that, Jen, you mentioned earlier that the regional extension centers out of the HITECH Act, fell short in terms of reaching the groups that they need. I'd love to see a revamped regional extension center concept. And the first person they should consult is you, because you really do have, 7 million patients out of these small, rural, under-resourced places where I'd love to see us come together and put together a program like that could strengthen it. It doesn't close the gap in terms of, it's not going to put a data scientist in every one of those. It's not going to put an ethicist, it's not going to do that. So I'd also like to see us developing, and maybe the government could support grants and things to develop concepts like the Project Echo in New Mexico, where that's extending clinical expertise, where they bring someone who's a clinical specialist in a certain area, and they have web sessions where people who are taking care of these patients out in these under-resourced, sometimes very rural and isolated areas, can get access to expertise, can get an understanding, they can get questions answered. And wow, a Project Echo for AI in under-resourced areas, I think that could be something really helpful. The other thing that I'd like to see out of the federal government is, I think that we need to set a more intentional research agenda around AI. And one of those is, let's describe some of the techniques that are being used in these under-resourced areas that I know that it's too early to talk about what's working and what isn't, but it might be good to start at least some research on the descriptive aspects of this. So let's describe it. And then as quickly as we can start to get to what's working, what isn't, so that it can inform not only those that are in those grassroots local settings, but the rest of us to understand how to help them.
Yeah. I think when we were working during COVID times, I think we call that promising practices, because we didn't have practices yet.
Promising, yes.
Things were moving right along, so we had to get something. So I think, I think that I'd love to kind of just expand a little bit on Laura's last part of Laura's question or answer around that workforce development and training. You know, I think that that's something we heard over and over again and during our project and on some of the informational calls is just how critical it is that this can't just be kind of one group of people trying to do it all. And so how can we achieve some of that workforce training? Are there particular programs that we might be able to use as an example? And let me start with Randy.
Well, I think for workforce, that's something that we've really been looking at, working with clinicians like the Coalition for Medical Specialty Societies and others that are just really interested in helping the various practitioners in their membership really feel good about what they're able to achieve. I think, Christina, we need, from a patient perspective, to really have a very far-reaching, across all sectors conversation. And AI in this conversation around governance really presents a focal point for that conversation. So as we're talking to insurers, or we're talking to employers, as we're looking at, you know, changing governments and priorities that we could leverage to try to make that case, I think we absolutely have to. The one thing we're also looking at is how can we use AI to help the people stay in the workforce, continue to contribute, and then leverage the breathing room perhaps that AI might bring to them, or the support that might bring them for a higher level of patient engagement. So we wouldn't want to have ambient listening suddenly free up clinicians from 21% of their reporting and note-taking be translated into more 6 to 8 minute doctor's visits. We would want to work with systems to say, how can we bring a qualitative improvement through the use of AI that does speak to the workforce and people's motivation to stay doing what they're doing?
Thank you. I'm going to say Laura and then Jen, and then we're going to let Maya have the last word.
Yeah, you know, this is something that we all need all across the country. I hate to see something replicated and duplicated over and over again that we all need. I'd love to see a large language model, maybe a small language model that's designed for this very purpose, that conducts the training for people, that it's conversational. These things are so engaging and easy to use. So thinking about it would be a consistent resource for them, no matter the day or night or whenever a large language model would be there for them. It would be able to sort of offer testing and assessment of, I think about these ambient listening tools, and I just would love to see the day when the ambient listening tool listens and gives feedback on the ability, the empathy that was involved, or it gives back feedback to develop the provider that's doing it. Now, we may not be ready for that, but I'm thinking, why not a large language model that would be designed for this, that would be extensible? One of the main things about AI, besides the fact that it's evolving so rapidly, it's ubiquitous and it's democratized, is that it scales so easily. And we build this once and we can use it all over the country.
Thanks, Laura. Jen?
Yeah, one of the things that I would suggest, though, is that we look at our workforce development nationally. That we have well-intended programs that are deployed by our federal partners that haven't necessarily kept up with modern times, specifically around data science, AI, as well as cybersecurity. And I'm going to interlink the two because I'm part of a national cyber effort to understand the needs of rural and underserved communities. And one of the big pieces is I don't have the staff on the ground, and I can't find people even to hire in this space. And I would say that that is very similar to what is happening with AI and understanding it. So being able to build a skilled workforce for the 21st century is going to be incumbent on the funding that comes down for federal government. So I just want to lift this up a little bit back to what can the government do, is thinking about how do we redesign programs, not only for our provider workforce, but for every operational function that delivers healthcare, because really it's going to be a vastly different world and a different modernized world. And to create sustainability in our rural and underserved populations, we need a workforce, whatever position that it is, coming in to be understood and understand this new world of data. And so we need to think about how do we modernize those workforce programs for today's needs versus what was around for 50 years ago.
Yeah, and I imagine part of that is understanding what do you need to know to be able to do these things? And you don't necessarily need to have, be able to build a large language model yourself to be able to understand and work with these tools in a safe and effective way and help with governance. And so kind of where is that, what is that level? And I think that that's not 100% clear right now. But I think that we need to find it because we can't, everyone can't get a PhD in AI.
That's right. And you don't have the people locally necessarily to support it. So how do you find the right partners? So again, going back to that trusted partner kind of conversation.
Thanks. Maya, you have the last word.
Absolutely. I think we each have a role to play when it comes to preparing the workforce of the future. We talked a little bit at the federal level. Definitely states are becoming increasingly interested on what they can do when it comes to state regulatory level. And so understanding your individual state and how they are developing programs towards AI literacy, data literacy broadly. And then at the institutional, team, and even individual level. So if you're in IT, or maybe if you're just IT curious, to Laura's point, there's a lot of resources out there, whether it's just even hopping onto ChatGPT right now and putting into the little prompt, tell me a little bit more about fairness metrics. It will actually output a pretty nice response. And so from that individual level, we all should be making sure that we're preparing ourselves for the workforce of the future. Our children are operating in a very different world than we currently have historically and are currently operating in. So they need to be adaptable and make sure that they're continuously learning these tools. But as well, ourselves as individuals, our teams, if you are an IT leader, how are you thinking about upskilling your workforce, especially as you go into your data transformation strategy or your digital transformation strategy, you're upskilling. Generally, you're doing some sort of portfolio rationalization. You're thinking about how to retire some applications in order to optimize other applications. And so in that process should be, how am I preparing my workforce that may no longer have a skill set that is as applicable today, that they have the resources to move into what we need for the present and future. So working with what you have, if you're an IT or an operational leader, and then working with your HR at that organizational level. So I think there's a role for each at each level, from individual all the way to government.
Thank you. What a great way to close out this wonderful discussion. I really want to thank every one of you for sharing your insights during this session. I'm going to take a moment now just to close us out. We're right at time. I want to thank all of our panelists and attendees for such an engaging event. I also want to thank our working group members for that helped us with our paper over the past year. I also want to thank the Duke Health team who helped put this session on, Nicoletta Ekanamu, Rebel Bag, and Jonathan McCall. And from the Duke-Margolis team, Val Parker, Maddie Cordell, Hannah Vitello, and Luke Durisher for all their efforts to help put this event together. As a reminder, additional meeting materials will be posted to the Duke-Margolis website in the coming days, including a recording of this workshop. Thank you again for such a wonderful event, and have a great afternoon.